If you're watching this, you've probably been diagnosed with multiple sclerosis, but do you actually have it? According to my guest, MS is very commonly misdiagnosed. So without further ado, I'd like to introduce Dr. Marwa Kaisey, who is a neurologist and multiple sclerosis specialist and researcher for Cedar Sinai in Los Angeles. She's also on Instagram and YouTube. Check out links to her social media in the notes below. Thank you, Dr. Kaisey, for taking the time to do the interview.
Thank you for having me.
So this is very concerning. How often is MS misdiagnosed?
So this is a phenomenon that any MS specialist will tell you that they see in their practice, but no one had ever put a number on it. So what we did is look at new patients coming into two completely independent MS clinics, Cedar Sinai and UCLA. And because part of our practice is to determine the diagnosis for every single new patient we see, we could tell how many of those patients have MS and how many did not actually have it. They had something else. And what we found, and this is really just looking at patients who are coming for reasons other than diagnosis, right? So these were not people who were referred with a question of diagnosis or for a second opinion on the diagnosis. They were coming to us for a question of disease-modifying therapy or just because their neurologist retired and they needed to find somebody else. And what we found is that at one clinic, 19% of those people who were coming in did not have MS, and at the other clinic, 17% did not have MS. So pretty similar numbers between these two completely independent clinics, and indicating that as many as up to 1 in 5 people with MS may not actually have it.
That's pretty astounding. I mean, I definitely see this phenomenon too, though maybe not 18%, probably a little bit less than that in my experience, unless I'm misdiagnosing people too, although I'm sure it varies by region. So what do these people actually have? The people who are misdiagnosed, what's the real diagnosis?
So one of the most common things that they have is migraine. And at the surface level, those two things sound very different, right? Like a neurologic syndrome that causes trouble walking or seeing versus a headache phenomenon. But if you drill down a little bit deeper, you can tell why they get confused. So the most common patient to be diagnosed with MS is a young woman in her 20s or 30s. That's also the most common type of patient to start having migraines. They can both cause neurologic symptoms that can come and go, and they can be focal even with migraines. So not a lot of people know that migraines can cause numbness, tingling, even sometimes weakness or trouble speaking for a certain period of time. And then most confusingly, they can both cause white spots in the brain. So lesions. And to a trained eye, you can usually tell the difference between a migraine dot and an MS lesion. But what happens a lot of times is people aren't looking at the MRIs themselves. The neurologist either doesn't have access or doesn't have the time to really drill down and look at the MRI picture. And they're relying on the radiologist's report, which usually says, hey, there are white spots in this MRI. This person may have migraines, may have MS, may have 7 other things, right? And it's up to the doctor to decide. So this is what we see most commonly getting confused with MS, although the list of other conditions was pretty long and pretty varied.
Yeah, and I know you mentioned some other things in the article, like peripheral neuropathy, which could cause numbness, which is seen in MS, and sometimes rare neurological diseases like neuromyelitis optica also. So what happens to these people who are misdiagnosed? I mean, you mentioned a lot of them, it's years and years of misdiagnosis, and a lot of them are on disease-modifying therapies, many of which could cause infections. What is your experience with these people? What happened to them when they got misdiagnosed?
So the people that we identified in our study had been misdiagnosed with MS anywhere from a few months to up to 19 years that they've been living with the wrong diagnosis. And over half of them had been treated with disease-modifying therapy. And in my mind, that's the most concrete evidence of the misdiagnosis, right? Is not only did someone tell this person they had MS, they went so far as to treat them with a medication specifically for MS. So they had been told they had the wrong diagnosis. They had taken the time and the mental energy to wrap their minds around having MS and this chronic neurologic condition. They'd started on medication, and a lot of times they'd pulled their friends and family into it, done fundraising for different foundations for MS, and it had almost become a part of their identity, right? The MS community is full of very strong people who are committed to fighting against MS. And so at that point, it's very, very difficult to tell someone you don't actually have this, right? It's become part of their life. And so that was something that we struggled with, was how to undiagnose someone, especially because we didn't always have the answers to what they actually had. We had more tests we wanted to run, but it wasn't always as straightforward as, oh, you don't have MS, but oh yeah, you have this other thing. It was, you don't have MS, we're sorry, but we have to run some other tests to figure out what you had. And that's really difficult for anyone to take in and to live with.
And I can understand that. Certainly, I've had some patients who have a lot of resistance to the idea that they don't have MS, even though MS is a bad disease. At least it gave them an explanation. So
Exactly.
my natural next question is, where are we going wrong? Neurologists, we're supposed to be smart and nerdy and conscientious, and we have fancy MRI machines. How are we misdiagnosing people?
So we are smart, we are nerdy, we are conscientious, we are all these things. I have the utmost respect for my colleagues, and this is not really meant to point fingers because what we found is that there was no one bad apple out there misdiagnosing all these people in LA, right? It was a different doctor for each of these misdiagnoses that came in. Otherwise, we just go talk to him or her, right? It's not that simple, unfortunately. So it was different people misdiagnosing them. Up to a quarter of the people that were misdiagnosed by MS specialists. So we do it too, despite all the beautiful training that we have and the thousands of people with MS that we see throughout our careers. So part of it is what our new study highlights, which is the lack of understanding of general neurologists of the McDonald criteria. So that's part of the problem is we don't have a single test to diagnose MS, right? It's not like a pregnancy test I can give you that says, yes, you have it or no, you don't. It's a set of pretty detailed criteria that you have to very conscientiously go through step by step. And it's easy to skip steps and it's easy to judge things as positive when they're actually negative. So that's part of it is that our criteria are complicated. We sometimes forget as we get out of training how to properly apply those criteria and how to strictly apply them. People are being a little bit loosey-goosey with them. That's what the new study shows is they would count a lesion as an MS lesion without it actually being that. And part of it, as I mentioned earlier, is not looking at the MRI because often we're just too busy to do that, especially in a general neurology clinic, and taking the radiologist summary of the MRI and using that to diagnose the patient. And again, that's not usually sufficient. So those are some of the reasons that we're misdiagnosing people. And part of it also, I think, is, as you mentioned, wanting to give a label to this person's symptoms and wanting to name their suffering in an effort to start to help them heal from it. And so I think part of our empathy as physicians also is just to try to help the patient get to the diagnosis, but sometimes that's either premature or just inaccurate.
Yeah, I mean, to share a few of my own stories, one of my patients was diagnosed with primary progressive MS for around 20 years, and he actually ended up having CADASIL, which is a rare genetic disease. And, I have another patient who was diagnosed with MS for a long time and actually ended up having Harding's disease, which is a rare form of Leber's hereditary optic neuropathy. But like your experience, a lot of the people don't really necessarily have any serious neurological disease. They may just have migraine or have benign white matter lesions. So what are sort of like the red flags? If I'm diagnosing a patient with MS, is there some sign I should look out for to say, hey, maybe this patient doesn't actually have MS?
That's a great question. So some of the things to look out for are symptoms that last for less than 24 hours. So for a real MS relapse, we really want to see something that lasts for more than 24 hours or will come back in the future, right? So that when we talk about migraines, usually those symptoms only last for a few hours. So that can help to distinguish the symptoms of the two. Another is a normal brain MRI. So you'd be surprised how many of the people that were misdiagnosed with MS didn't actually have any lesions in their brain, which is one of the key criteria for having MS. And then the other is a lack of both cord lesions and spinal fluid oligoclonal bands. So if you don't have either of these, you can still have MS for sure, but it should raise a slight suspicion in the neurologist that this person may not have MS. So a lot of the MS mimics don't cause spinal cord lesions. So that's one way to kind of start to distinguish between the two. And then we've kind of gone back to using spinal fluid more than I think we did when I was training a few years ago now with the new McDonald criteria, since the spinal fluid can help satisfy some of those criteria. And there is no one test for MS, so even the spinal fluid is not definitive, right? Even if you have normal spinal fluid, you can have MS. But if that's the case, I really want my patient to have classic symptoms and a classic brain MRI, right? They're not getting away with atypical symptoms, an atypical brain MRI, and normal spinal fluid. In that case, that's most likely not MS.
Yeah. Now, so what is the way to solve this problem from a big picture perspective? A lot of people have said, hey, we have to make the diagnosis of MS idiot proof. And the way to do that is to have some kind of test that diagnoses MS on its own. And one thing people have proposed is this finding on MRI scans of having a vein in the center of multiple sclerosis lesions, because MS is a perivenular disease. So you talk about the central vein sign that may help us diagnose MS going forward. Can you tell us a little bit about that?
Sure. So this was an MRI technology that was developed by Dr. Pascal Satie, who's now at Cedar Sinai with us. And what he really used to develop this was the theory that MS lesions don't just form willy-nilly anywhere in the brain, that they form around some of the small blood vessels in the brain. And that's because MS is really a disease of the immune system. You can fight me on this, but I don't think it's a disease of the nervous system. It's a disease of the immune system. The immune cells misbehave. And those blood vessels where the blood flow slows down a little bit allow those immune cells to go out into the brain tissue around the blood vessel and start causing that damage, that demyelination that becomes an MS lesion. So you can see this on an MRI. You can't see it on the typical MRI that we do usually, but you can see it on an MRI that's the flare sequence that we usually do for MS lesions, layered on top of a sequence that looks at blood vessels. It's more commonly used in the stroke world. So to the patient, this feels like a regular MRI. They don't notice a difference, but the magic is in the post-processing when we layer the images on top of each other. And what that shows us is where the MS lesions are sitting in relation to the blood vessels. And if someone has the majority of their lesions sitting around the blood vessel, then they very likely have MS. And if those lesions are not around the blood vessel, between the blood vessels, they most likely have something else like migraine or like a ischemic disease where the lesions are forming away from the blood supply in the brain. So this is something that's been pretty well studied in MS over the last few years. The final definitive study is going on right now. It's called the CAVS MS study. And we're the hub of that, but there's 11 sites across North America that are recruiting right now. And what this will do is allow the radiologist to really say with pretty good certainty, this person probably has MS, or you really should think about the MS diagnosis because I don't think that's accurate here. So we're getting a step closer to the idiot-proofing of the diagnostic process, as you called it, right from the beginning, right from when that patient gets their first brain MRI.
Yeah, so, there's no doubt in my mind that this technique works, but not to be a skeptic, but maybe it's not perfect. From one of your articles, using the threshold of 29% of the lesions having a central vein, vessel, it only had 79% sensitivity, meaning you're definitely missing some people who actually have MS, and 88% specificity, meaning that it's not perfect at excluding not MS, and maybe it was 87% accurate overall in the people that you felt were misdiagnosed. So how good is it? Is it good enough that we can actually use it, or do we need to use it in conjunction with our general feelings, our clinical beliefs, the spinal tap, other factors?
I definitely think we need to use it in conjunction with those other things. So this is just another tool to help us in the diagnostic process. So as you mentioned in our study, we found that out of the people who had been misdiagnosed by the regular clinical process, this test picked up 87% of them, which is pretty good. Compared to just our usual process, it picked up 87% of people who had been told they had MS who actually didn't. So it can definitely help. I don't think we're anywhere close to having a single tool that can replace our current process. I mean, it has to start with a neurologist or a physician thinking this person might have MS, I'd better send them for a brain MRI, right? So part of it is that clinical suspicion. And this just helps to really distinguish MS from its mimics once we get down to that point. So I hope and I think that this may be part of our diagnostic criteria eventually, especially after the conclusion of this huge study, which is going to enroll 400 people and give us more rigorous data. You mentioned the 29% rate. A lot of other studies have found slightly higher, 35, 40%. So part of it is going to be defining where our cutoff is, right? Because every study is slightly different, and this is going to be one of the largest studies and to help us do that. But again, I agree. I don't think this is going to replace our current process, but it's definitely going to help us to make it more accurate.
Yeah, and one other thing I came across is some other rare neurological diseases such as Behçet's disease or primary central nervous system angiitis. You could potentially also see the central vein sign there. Is there anything else people should be aware of in terms of using this technique in the future?
Those are some of the things. I think that the one kind of other, not just mimic that we're worried about, but the applicability worldwide, right? And in community radiology centers is the way that we did our study is we literally one by one counted every single lesion on the brain MRI and then counted how many of them had central veins. And you can imagine this took forever. It was a very painful process. I did it myself, so I can tell you. And we had 2 raters, and it wasn't 100. It was very good agreement, but it wasn't 100% perfect agreement. So one of the other things we're working on is to automate this process, to use artificial intelligence to do the work for the radiologist. And I think that's going to be a key step towards getting it available everywhere.
All right. Well, this is all great information. Do you have any final words for someone who has a diagnosis of MS and maybe they want to double check and make sure it's right, or to clinicians out there who want some words of wisdom?
I think it's something for the clinicians is that if you're seeing somebody with MS for the first time, they're new to your clinic, no matter how long they've had the diagnosis or how experienced the person who was managing them before you is, I do think it's worth it to double check the diagnosis, to go through the diagnostic criteria, ask that person about their history, how they got diagnosed with MS, what their symptoms have been, and to try, if you have access to it and the time to do this, to look at the MRI yourself and make sure you agree that it has those typical MS lesions that we need to confirm the diagnosis. I think that one step, not always easy, it takes time and it takes some resources, can help prevent a lot of these misdiagnoses. And so to the patient, that's also something that you can ask your physician is how sure are you that I have MS? Do I meet the diagnostic criteria? And it's not possible for everyone, but to try to see an MS specialist at least once and try to do it towards the beginning of your diagnosis if you can, to confirm the diagnosis and to really talk about what treatments might be appropriate for you and so what lifestyle measures you might want to implement. Again, most people are managed by general neurologists, and that's wonderful and that's perfectly sufficient. But if you can see a specialist early on to talk about the diagnosis in more depth and to think about treatment plans, that can often be really useful too.
I think that's all great advice. Thank you for taking the time again. Again, definitely check out Dr. Kaisey's YouTube channel, link below. And if you have questions, please post in the comments below.